gracias.
Thank you. Buenos días todo el mundo. Estoy muy agradecida hoy de chismear, charlar con ustedes y hacer lo demás, okay? Hi, I'm going to talk in English, I promise. I'm going to start where I come from. So Yamile, please feel free to connect with me over coffee later on. I'm going to try to be as quick and as efficient as possible, but those terms and adjectives are never really applied to me, so just for reference on that. So what I'm going to do is just give a quick connection in terms of why community engagement and network science is an easy partnership. I'm really excited to be here today porque I will tell you most of my life is spent talking to interventionists about why network methods are important, and now I get to talk about how network methods are awesome with people who know that they're awesome. So it'll be a real quick overview. Then I'm going to give you a couple examples of some of the work I've done over the last 8 years or so with Latina and Black populations, and we'll go from there. So here are the 3 things I want you to come away with. 1, community partners value, and as we already heard, already do network interventions. So that's already happening, so it's easy buy-in. They are already doing it. They're using different languages. They get it. They get the value. Number 2, communities value and actually want network-based evaluation because it actually aligns with what they see in real life. The complexity that they see in real life settings as they are doing the work, network methods match it, so they're all in. 3, community perspective has added value to our network science. That goes from agent-based modeling to other simulation models to very complex work on empirical data. They're here for it, they can give advice, and really it's about inclusive communication and really ensuring that we're on the same page first and setting that forward. So con eso, like I said before, and as was mentioned by this big jefe here, which is always very scary when you're like, I've cited you a million times, oh no, look at me. With that in mind, community interventions more often than not are at least network-esque, and that's important to note. There are often opinion leaders, they can call them promotores, volunteers, advocates, patient champions, citizen scientists, navigators, name it, they're there. Oftentimes they're self-identified, self-nominated leaders who are well connected in the community, and part of their job description is their ability to connect and interface with a number of community partners, right? And so the idea is often that they are out there serving as hubs and really getting that word out there. So they get it. They love the idea of network interventions. They love the idea of adding complexity and doing some intentionality of that work. Number 2, like I said before, oftentimes community programming, and here I'm not talking about public health in the context of in a university setting. I'm talking about the grassroots organizations that exist. I'm talking about public health departments, churches in rural settings, and the like. They are already doing this work where they have their interventionists, their team, right, who is working and touching base. What they also know is that that's not the easiest picture, that our standard public health evaluation methods don't capture the fact that, for example, participants know each other and brought other people to the table, and that needs to be incorporated and added to it. They also know that beyond the program settings, each of these participants is potentially reaching out to other community members. So I say this to just throw out there that community engagement and network methods are very easy, because once you bring in exactly what you're hoping to do and what you think is going on, oftentimes we're like, yeah, that's exactly right. I'll give you an example, which is the first time I did this in 2013. I was in California working with some promotoras, and they were talking to me about, I was telling them about network interventions and really understanding those positive ripple effects. And they were like, oh yeah, I'll talk to Fulanita at noon. I'll have her mother-in-law at the table calling me at 9 at night, which also, by the way, speaks to the fact that we need to invest in community because community health workers are always on call, right? So with that said, they believe the methods, they want the methods, they want that critical, comprehensive, and precise data. In addition to that, they believe and argue and actually have advocated and pushed me into a different space in terms of not only showing how much more they're actually reaching the community, but the value of that, so really incorporating cost data and really thinking about the fact that adding network effects really helps us have a more comprehensive and precise estimate of how much value these community interventions that have positive effects, usually how much value actually is associated with them and how much we are actually gaining. So the final piece, I'm going to focus on my first 2 points primarily, but I'm just going to throw out there over café if we want to hang out at any point. Happy to talk about my experiences with how to do community engaged work in terms of secondary analysis, primary analysis, computational models, you name it. Happy to talk about it, best tips. What I will tell you is how many people love complex modeling? All over, right? You know who loves complexity? Community, because they're always saying it's harder than you think. So they get it. You know how many people understand in community that we love complexity, but we gotta actually do the thing, and it has to be feasible. Community gets it. You know who else gets it? Modelers, who are like, yeah, I get the world is completely complex. We got to prioritize where we're going to put complexity in this for this model to run. Community gets that, right? Finally, community gets being creative. They get the idea and the notion that we have to shift and move, right? So I would just provide some support, and I'm happy to talk through strategies for engaging because they want to be with the data with us. They want to give input, and they have value because their lived experience and their vantage point sometimes aligns with our theory and sometimes can expand on our theory and our models. So I'm going to start off and I'll give you a couple of real life examples. I'll go through it as quick as I can. I talk pretty quickly, but todo bien, we're all good? Dale. Okay, so I'm going to first talk about something that we don't often talk about with network methods and really highlight that network interventions in of themselves can be powerful and impactful to the most vulnerable people just by training and recognizing them as assets. So that's to say, understanding that education is power in the true sense like Ferrer said, and really understanding that our participants are our next interventionists. So con eso, I want to just first recognize my community of folks who have been in this project for a long time. A critical part for me of community engagement and effective cancer health equity work is inclusive leadership and elevating community as academics, as well as community leaders and representing that. So this is a community of Latina investigators. Some of them are now doctors, some of them are now PhD students, some of them are now public health practitioners. Y todas have been in the fight. So si se puede, and it already has been done. So con eso. When I focus in on the projects, I focus primarily in breast cancer. That's the majority of my work. You're going to see me talk a little bit about a couple of outcomes. A lot of times what we see is communities who've been historically excluded from care, so not underserved, but historically excluded from care opportunities, really and truly have had challenges with adhering to the guidelines that we give them, but do not give them access to the knowledge base as to when they should be doing it. We don't give them access to actually getting it. Right? So with that in mind, the work that I've done is really focused on how do we get them access to the evidence, how do we get them access to the care in the ways that it's done. So with that in mind, I'm just going to throw out there that a lot of these cancer disparities have been around for decades with the advancements of new treatments. And so oftentimes, for example, when I talk about breast cancer disparities among Latinas, which is relatively, I would say, less known, what people don't understand is that there are 3 meta-analyses today that show that Latinas have worse quality of life relative to non-Hispanic whites and other ethnic groups post-diagnosis. 3 meta-analyses, not 3 studies. So I just want to throw that out there. We know the problem. We also have been trying solutions. So going into this, there have been a number of community interventions focusing on different health topics. I focus again on cancer, but I'm just going to highlight 3 of the common strategies that we see in behavioral interventions for health equity work. So with that in mind, we have first, systematic or organizational change. So specifically, patient navigation or case management to getting people to free and low-cost care, right? And so that is at the systematic level in terms of ensuring that care is affordable and accessible, and that someone is there to provide you with supports to deal with the barriers that you have. Next, we have the train-the-trainer models, or community leadership models, opinion leader models, if you will, wherein we invest in community leaders who are already present, give them access to the knowledge base with the understanding that they're going to disseminate that. And the final thing is that those individuals who have been provided enhancements in terms of their capacity and given the content to leverage their skills, that do that with patient education. Usually with community clinical academic partnerships, what we see is a mixture of the following. We have clinical facilities who have navigators, if you will, social worker aides and the like. We're providing that care, that free care, that high quality care in a low setting. We have community partners who have a lot of training, potentially from academic settings, in terms of what information is available, how to build their capacity, help with their message and disseminate it. And then simultaneously, we have those individuals who are out there in the community doing. Now, with all that said, here's what's most interesting. More often than not in the context of breast cancer, as we would expect, the number one most consistently effective strategy, free care. You want to know the one that works the best anytime, every time? Oh, it's free care, right? So I'll just leave comments there, I won't get political. Free care, I've been political enough. But 2, with that said, free care is only available to whom? The people who know that free care is there, right? So what we've also seen consistently across the literature with different systematic reviews is the importance and the value of community interventions of those opinion leaders, as was mentioned before. So with that in mind, what is the best strategy to get that information out there, to get information about those resources that already exist, that are structurally present? About 8 years ago, my community partners and I really focused on a new an aged new type of model. We were calling it the Empower model. And part of this idea is really understanding that the people who we consider the most vulnerable, the most threatened, the most historically marginalized, haven't been waiting around for us. They're actually doing things on their own. Miracle, right? We all believe it, right? So with that in mind, people who are most and utterly disenfranchised have the capacity to make their testimony the most important testimony. They have the ability to really change minds in ways that no one else can, right? And so with that in mind, we came up with this idea, which is really emerging with the different types of network interventions that were mentioned before, which is we have an opinion leader, we have a central node, and the understanding that we should be modeling every individual's then dissemination and engagement with their network members. So really thinking about and training our participants to then pass the word. Think about this as training the trainer, if you will, or understanding that when we give knowledge, the expectation should be not only that the people are receiving it for themselves, but that they're going to be passing it on to others. So with that in mind, why would we do that, right? How many people have talked before or given a presentation before? How many people feel like the first time you learned something was when you had to teach it and a lot of people were staring at you terrified? You were terrified, they weren't terrified, they were blank-faced, right? So eso, right? Part of the network intervention and part of training and understanding and engaging patients, participants, clients, as people who are going to be sharing that information, assuming that they are going to be the leaders in that set, puts them on the pressure line, actually. It's not a great feeling, as we all know. Because now, we're being told, here's the message, you gotta spread it to the 3 people that you care about the most. You know what's gonna happen? You're gonna really remember that. Because those people you care about the most, you care about what? More than you care about yourself, right? So now the pressure is on to own and retain health knowledge, and we have some preliminary data to suggest that network interventions lead to greater consolidated knowledge information. It also leads to greater pressure to be a healthy role model. Como puede said that I will tell you to get a mammogram if I haven't gotten a mammogram myself. So that social pressure is there, right? And then simultaneously, you get exposed potentially to a shift in your network, and potentially you get to see the model in action. So when you are referring other people, your family and your friends, to that space, you not only are getting your personal experience, but you're watching the system, you're watching the networks, you're seeing what's going on. And that greater exposure, that hands-on experience, right, will facilitate personal health behavior change as much as it is associated with network level effects. So how do we do this? How do we do the actual intervention? The programs that we have developed are really a mixture of first, social navigation, using the social determinants of health framework, right, to free and low-cost screening and essentially free and low-cost breast health care across the board, right? And so with that in mind, in the context of free care and facilitated care and support for any other systematic or structural barriers, we've been comparing and contrasting the best practices or the standard care, which is something. The standard care today is really access to education, so information about breast cancer 101, the risks, the screening methods that are available, methods of prevention like diet and exercise. And then with that information, if you want to, you can get navigated to the screening as you've been told. So that's our control. That's a really hard, high control yes. Our intervention, or the network intervention that I'd like to introduce you to, is the Empower Navigated Intervention, or just Empower for events. What we do with this is we turn it around. We do the first same session, Breast Cancer 101, here are your risks through the screening methods. The second session we say, okay, you learned it for you, now learn it for someone else. We do an action plan, we do tailored information around, pick up to 3 new people that you want to talk to about that. Here's the thing, about 70% of participants who don't know what's coming, by the way, at that second session are like, oh yeah, I already talked to my daughter about this. Recognizing that the people we consider to be most marginalized are doing something, and our acting is our critical resource. It requires us to do a paradigm shift. We're working with communities because communities are getting it done. They need the investment, right? So I'll stop preaching for now, 1 minute. But with that in mind, our second session, so first you learn it for you, second you learn it for your family and friends at an interpersonal section. The third session that we do is we offer 2 options. Option 1 is participants can bring a family or a friend if they're not really necessarily comfortable with sharing that information. They can do it with the support of the community health worker who's giving it. Or they can get connected to different opportunities to volunteer and work with other community health workers and become part of the team in whatever sense feels comfortable. What I'm going to tell you now, something that will potentially come to your mind is, okay, this is great, but what about the people who don't want to volunteer and don't want to share this information? What about the introverts, which PS I am? I just don't look like it. So with that in mind, just throwing that out and giving you the key thing, this works in particular very well with the people who would not otherwise disseminate the information. Why? Because how we section this is really tailoring and understanding that what leadership looks like depends on a different person. For some women, it's getting on the mic. For a lot of women, it's passing out flyers outside of the church, or leaving flyers on a bus seat, for example. And that counts. That dissemination matters and is valuable because it changes community norms and values, right? So recognizing and appreciating that actually leads us to have particularly high success for the people who even don't share the information. And these are usually the people who have been due or non-adherent to guidelines for many years. So their personal behavior change matters particularly to us. So here's our conceptual framework. I know I'm going too long, so I'm going to go over it really quickly. And with that in mind, just note that relative to education of that standard of care, the primary goal is that empowerment or a leadership perspective leads to greater knowledge retention, greater pressure to be a leader, and therefore to the behavior. And that's going to lead to different health behaviors or improved health behaviors. It's going to lead to individuals who are particularly effective, not because they were central to the networks that they were in, but because they have a story of how they were challenged and how they changed it around. So with that in mind, that leads to network members diffusion, and that leads to more of an intentional diffusion in the community, if you will, of high quality message. Why? Because we're not assuming that only the community health worker needs to be trained as an active messenger, but everyone needs to be trained as a solid, intentional, strategic messenger. So here are the 3 grants that we've gotten to test the way around it. I'll talk folks first primarily about the K01, which is a quasi-experimental design, and then I'll touch base on one of the RCTs, randomized control trials we've been doing for the last 2 years. This one, the R01, we just got last August. We got 40 people enrolled. Woo! So, next time. Pero con eso, let me tell you a little bit about the K01 and the initial study that was in 2016. So I'm from Chicago. The actual Chicago person in the room is like, I dare you to do that one more time. So I am from Cook County. Currently, I love it. And so the work that I have done has really focused on the west and the south sides of Chicagoland, the Chicagoland area, focusing on predominantly Latino communities where over a third of residents are impoverished or below the federal poverty line. We focused for this initial study on partners and community agencies who already had those strong assets. So the thing you'll hear me say over and over again is community is doing this. It's about us becoming informed, not informing them. Understanding what they are doing and moving our methods towards that. So with that in mind, we picked interventionists who are already doing leadership or train-the-trainer models, people who were already doing education and navigation, and we asked them to continue doing that work and get paid by the government. Woo, right? So with that in mind, we also focused on participants. Something I want to highlight to you is that in order to participate in the study, you could not want to get a mammogram. You could not want to get a breast cancer screening. So actually, at that point in time, if we approached them, they were like, yeah, I need a mammogram and I want to be in the study, we refer them to get the mammogram. Because they didn't necessarily need that information. We're trying to get the people who are most vulnerable in terms of not sure that they want to do this for various reasons, a number of reasons. So these were individuals who had not had a mammogram at least in 2 years, were 52 to 74 years old, had no intention of getting it when offered explicitly a warm handoff to a mammogram program, and lived in the 2 neighborhoods that I'm talking about, the west and the south side, and had no experience with volunteerism, which is also, of course, important if we're saying that leadership works. We don't want you already to have had that training. So I'm going to go through this really quickly. Essentially, we had the standard covariates mammography use, which was our outcome of interest for breast cancer screening. We picked their baseline, the intention, even after they said they did not want it now, what they expected to do over the next year, and then whether they actually got a mammogram based off of medical records / self-report. And then we use the general social surrogate instrument, or just that basic egocentric measure, to really assess network effects. We got about 145 individuals. We assigned them again by program. So the west side got the leadership model, the south side got the education and navigation model. The reason why we focused on neighborhood effects is because we were worried about contamination or spillover effects. So just as an aside, we are doing the RC because we didn't see as much challenge in terms of contamination once we quantified it, but that was an initial concern, so that's why we wanted to pause it first. So with that in mind, I'll just highlight the majority of women were between 52 to 64 years old, primarily of Mexican descent. About 61 to 54% had less than a 9th grade education. And something I like to point out often is 2/3 an annual household income of less than $15,000 a year in the freaking United States. Take out the word freaking. Less than $15,000 for your family, not for you alone. So I just want to highlight this. When we invest in communities, and that's really the policy implication that I'm happy to talk about later, we should invest in those individuals who are most impoverished and most in need. Because 15,000 as a household income is something that is a public health priority as much as breast cancer. So with that in mind, in terms of the different arms, going back to the science, what we see is that our control arm actually was more likely to have insurance. Our intervention arm was more likely to say they wanted a mammogram, though they had rejected that warm handoff. So what did we find in terms of the data? Here's what I want to highlight and remind you all of. Everyone had access to free care. Everyone had access to need and navigation in terms of housing needs, telephone needs, what you will. That was the same across arms. The only difference was recognizing somebody as a leader, thinking through the participants, and letting them know that we believe that they were going to share that information and working with them on the message. It was the only difference. With that in mind, we see 72% of individuals who were treated as leaders got mammograms relative to 48% of individuals who were treated as passive recipients. I want to highlight that when we actually look at this among people who didn't talk to any of their network members, we still see about this amount of difference, or about a 20% difference. So it doesn't necessarily mean that you have to do network members. This is where network interventions we don't talk about often. Network interventions in and of themselves can benefit the agents who are doing it. So why not do network interventions with the people whose behavior we want to support? Because they can be, one, good leaders, but two, even if they're not out there in the community, they're out here in the community because they represent the community. So with that said, like I mentioned before, we have an RCT. We've changed it up a little bit. Now we're working with FQHC, or Federally Qualified Health Center participants. Federally Qualified Health Centers being community centers in impoverished area communities who are that safety net. We are now focusing specifically on genetic counseling and testing, which is a slightly different bird, with the idea that actually if you know your risk, and if you are identified as having high or elevated genetic risk, you can get a free or covered breast MRI. Twice a year, covered by the state, covered by the CDC funds for it. And so moving into the space that risk-based care is becoming more and more accessible, does this in-network intervention actually lead to better behavior for women who are, or patients I should say, who are Latina, don't have health-related volunteerism, and have either had breast cancer or ovarian cancer, or have a first-degree family member that have not gone genetic testing. So the only difference in terms of metrics is the outcome itself. We've assessed whether they would be interested in doing an assessment to figure out what their risk is, and then doing genetic counseling and testing to determine and confirm high risk for the having a mutation, if you will. So relatively small, we just started, yes. But we've got about 78 randomly assigned, which is about 2/3 of the sample that we want to get. And just to note here, we have essentially a very similar population. What I want to highlight with the RCT that we didn't do previously is we have confirmed or documented information around their risks. So even though most people are insured, funnily enough, about 83% or about 80% overall have financial hardship that does not allow them to access health care and is a daily challenge in their minds. With that in mind, we also have a third or over a third who are exposed to domestic violence, have unstable housing, have travel instability, and the like. With that in mind, what's the impact of treating individuals like leaders? Just assuming that they are going to do it and entailing a leadership plan. What we see here is with an outcome that is primarily access to phone-based care, we have relatively comparable uptake. Everyone's requested these services in terms of assessment and all that. But when you actually look at who gets assessment, we see the numbers slightly change. And then when you look at among the individuals who've been identified to be potentially at high risk, we have 60% in the Empower arm who have gone on and gotten the genetic counseling and testing relative to 19% of education. What I want to highlight here again is everything is the same in terms of navigation and addressing structural barriers. The major difference is treating and respecting patients and clients as our leaders and our partners in this. So with that in mind, hopefully I've given you a preliminary information. There's a mess of study design limitations. We can talk all about them, and you can write me on them. It's great. I'm good with it. But hopefully I've given you some evidence to suggest that network interventions may benefit the most vulnerable and resilient when we incorporate them as the leaders in these interventions, not only as the recipients. Just really quickly, because everyone's like, yeah, but we talked about networks. Give me a network, please. Okay, so with that in mind, what were the network outcomes that we saw? Just to throw out there, when we treat people and engage them and give them action plans to do it, it turns out they reach more people. We're surprised. Fully surprised on this, right? So 41% reaching more than 7 network members across 6 months relative to 20% when you're giving the information. Simultaneously, there's also greater depth in terms of message quality and a focus on mammography recommendations or mammography guidelines, because what you talk about matters as well. What I want to highlight here is these ain't 0%, right? So just highlighting this is a message that has been published by many people in this room often before, not staring, right? Networking methods are particularly important for all behavioral interventions. So that's to say it doesn't have to be a network intervention for network metrics to matter. So that's the quick thing I'm going to mention really quickly now, is that network methods are a way to measure all community event interventions, just in general. Because more often than not, especially in marginalized and resilient communities, those positive spillover effects are going to happen and are going to be particularly strong. Here, I just want to acknowledge the great team that I have for the project called Oasis, which was an R21 I was doing concurrently with the work with Latinas. I want to recognize Nayan Bergeron, who's in the room here today, and I want to just say that all this work was 100% elevated by her. She did everything, and she's currently doing a network intervention looking at weight management and how to do network interventions, not weight management, and is doing this work and has adapted it, and it's phenomenal. So you should talk to Nayan, it's very good. She doesn't want to do that. Okay, that's fine. So I want to also recognize Aditya Khanna, John Schneider, Kareem Watson. Aditya and Kareem were MPIs on this. And this is, again, just investment in excellence and recognizing that excellence is happening and saying that as much as is possible. So with that in mind, our R21, really quickly, we were doing a 2-level egocentric analysis. We essentially engaged individuals who were navigated versus not navigated. And navigation was not network-based. It was just giving information and getting them to the care that they wanted. And we looked at African-American women who had previously been randomly assigned to either get that navigation, get that extra support, or get standard care. We engaged them, about 100 of them, and then we engaged about 142 of their network members, family, friends, and the like. And we assessed how their breast health screening behaviors might be different, or what was that quantitative difference between the quantitative difference in terms of network effects of navigation. Today I'm going to talk really quickly about the cost analyses. I'll be real fast, I promise. And just highlight the benefit of network methods when incorporated and integrated into cost models. I would also throw out there, if you want to talk about agent-based models, Aditya was the master of this, but I can talk a little bit about it later. So here were really quickly the 2 scenarios that we compared. Number 1 was baseline, number 2 was network. Baseline is standard cost interventions. How much money does it cost to help every additional person get a breast cancer screening, for example? So pretty standard. The network one was, how much are we paying for all the people who are getting mammograms? Not only the participants, but the network members that they touch. So a slight difference. In terms of cost data, the main difference is that in the standard care arm, we incorporated the costs of getting people mammograms, which is costly still. So we would have the number of individuals times how much it costs to get a mammogram. For navigation, we incorporated the costs of counseling and doing the arrangements, any mailings and cards like that, the time of the navigator's salary, and then the medical mammograms themselves. With the network scenario, here's where I will throw out there, it was really interesting. Like I said before, this was not a network intervention. So the navigators never touched base, never trained them, never gave any information around spreading the word. So with that in mind, we kept the navigation costs exactly the same. What we saw from our network data is that most of the diffusion of information, the mammography promotion, was happening in natural family encounters. So there was no additional time spent that we needed to account for in our cost analyses. With that in mind also, there wasn't any training, there was no touch point between the navigator and the network member. It was purely through the navigated patient who was doing the work. The only costs or added costs that we had were that we incorporated the additional screening mammogram costs for patients and network members. That was the fundamental difference in terms of costs, just accounting for the amount of money it takes for more people to get mammograms. And we did it to 2,000 patients. In terms of the baseline effects, we got screening mammogram data from the electronic health record, and just did a simple equation on there. So we saw that about 45% of navigated patients were getting regular screenings relative to non-navigated patients. What we did in terms of the network effects is we did a fun process, if you will. We took the patient data, and then for the network members, what we did is we took the average number of network members who obtained mammograms through self-report for navigated and non-navigated members, and then we adjusted it and said essentially half of those don't count because they wouldn't be able to be confirmed in terms of medical records. So we took a conservative approach to that and really tried to make sure that we were taking as conservative an approach in terms of those extra mammograms as is possible. So here's what we found. When you include only patients, you only assume that navigation only works with patients, that patients are not doing anything with the information that's given to them. What we see is that it's about almost $4,000 for every additional mammogram. So think about this as a politician, think about this as a civic leader, think about this as a hospital administrator. It's about $4,000 per additional one. And the actual difference was about 60 people. So we get about 60 extra people when we navigate and provide that support. So think about that. Now think about when you have network information. So when we incorporate and understand and collect data and incorporate the fact that patients who are navigated, patients who are not navigated, are spreading the word, are potentially having these spillover positive network effects, what we see is that there are 273 extra mammograms for navigation relative to not giving navigation. And actually we see the reduction where it's about $1,000 for every additional mammogram. So network data matter. They can help us make better investments, better resource allocation, and we should be doing it. Also, we can talk more about this, but we did a bunch of network estimations in terms of how we control the network effect and who was doing network navigation and all of that. So con eso, network methods work. They should be used. Community interventions are already having spillover effects, whether or not they're talking through train-the-trainer models. We're not capturing that. They are doing it, and they want us to do it. They want us to partner with us, and NCI should fund us because it's being recorded. So with that in mind, my conclusions which were the very beginning. Hopefully I've convinced you. Community engagement and network science, hand in hand. We are talking different languages sometimes. Sometimes we're talking the same language, and we should just foster that. Number two, understanding that network interventions are most helpful for those who are most vulnerable, who are also the next resource leaders, right? And that network methods can be helpful just in general, regardless of whether you're doing a network intervention or not, can actually give you a more comprehensive effect and a more comprehensive cost effectiveness data. Con eso, gracias. I'm sorry I went over, I know I did. Sorry, there was a camera, that's why I did the piece.
Awesome. If there's any quick follow-up questions, and then we do the flip over here.
Primero quería decir que gracias huirme idioma en este espacio. My question for you is, I'm really thrilled to hear about the cost effectiveness data, and I know that there's a lot more investment in these kinds of network interventions at the public health level, including a lot more sort of formalization and certification. And I'm wondering what your thoughts are about the sort of pros and cons of that approach.
Yeah, I think that right now as we're moving towards certification, especially those opinion leaders and all of that, it's completely critical that we really accurately estimate how many people they're reaching, which is not only the people they're reaching, it's all the calls that they don't mention, right? And so for those listeners, opinion leaders, they try to be minimal. They don't tell you all that they're doing, they don't brag, right, in that way. And so I think that it'll be really critical to incorporate network methods in statewide and state health department models. We've done a little bit of work that's already in the the Chicago Department of Public Health, really showcasing them, look at how many people we're actually reaching when we think about network members, when we commit people to it. And they're liking that. I think in the context of the cost data, there are, of course, a number of ways to go. The good news and what I've been really advocating for to the cost folks as well as the health departments is when you use those standard egocentric network measures, as simple as they are, you can get a pretty good estimate, right? So you don't have to go fully deep if you are nervous or you want to pilot test it. And that's got me a lot of phone numbers. So, okay, yeah.